Okay, we're going to continue with Chapter 42, Part 2 of The Child with Cardiac Disorders. We're going to talk about acyanotic defects. These are defects with increased blood flow. We have the increased pulmonary blood flow. Blood returns to the right ventricle and recirculates through the lungs before exiting the left ventricle via the aorta. Shunting, blood shunts from the left atrium to the right atrium. We have the atrial septal defect. From the left ventricle to the right ventricle is the ventricular septal defect, or from the aorta to the pulmonary artery, also known as patent ductus arteriosus. These defects are acyanotic because blood shunts from the left to the right, which means that oxygenated blood is recirculating through the lungs, and cyanosis is not initially a clinical manifestation of this defect. You want to look at box 42-1 on pages 1322 to 1323 of your textbook. Okay, let's talk about atrial septal defect, also known as ASD. It's an abnormal opening between the right and left atria. Oxygenated blood is forced from the left atrium back to the right, then through the tricuspid valve to the right ventricle, and so on. You may hear a murmur upon auscultation. Most patients have no symptoms. Diagnosis is after hearing the murmur, may have a cardiac cath, an ECG, an echocardiogram for confirmation. It's the least invasive first is what you need to choose. For repair, it involves surgical placement of a patch or repair with cardiac catheterization. Follow-up will continue to follow up with a cardiologist on a routine basis. Medication may take a low-dose aspirin is usually prescribed for 6 months after a repair, and prognosis is excellent. For the ventricular septal defect, also known as VSD, it's most common congenital heart anomaly. There's an abnormal opening between the right and left ventricles of the heart. Due to increased pressure in the ventricle, blood is shunted from the left to the right rather than flowing left to right. You'll hear a loud, harsh murmur and a systolic thrill upon auscultation. It's often associated with other defects. There may be spontaneous resolution. If it's a small defect, it may resolve spontaneously within the first year of life as a result of normal growth and development. As the opening decreases in diameter, the murmur becomes more audible. For repair, small defects may be closed during cardiac cath. However, open heart surgery may be performed on larger defects, with the opening being closed with a suture or a synthetic patch. Early intervention decreases associated risk for most infants. Normal growth and development is typically achieved within 1 or 2 years after surgery, and prognosis is excellent. Okay, let's talk about atrioventricular canal defect. Defect that occurs as a combination of an ASD and VSD creates a large central AV valve that allows blood to flow between all 4 heart chambers. As a result of the pathophysiology of the defect, the child is predisposed to CHF. Typically hear a loud systolic murmur, maybe mild cyanosis, because it is a large defect that affects blood flow greatly. It is palliative treatment. The pulmonary artery banding is small infants with severe symptoms. For complete repair, most common treatment consists of a patch closure of the septal defects and reconstruction of the AV valve tissue. Prognosis is good. Mortality is less than 5%. Later effects, they may develop mitral valve regurgitation, which may result in a need for a valve replacement. Okay, PDA, patent ductus arteriosus. Fetal circulation, there's a normal shunting from the pulmonary artery to the aorta to avoid the deflated lungs. So where does oxygen take place? The placenta. So it normally closes shortly after birth. After birth, if it's not closed, the blood will shunt from left to right due to the increased pressure from the ventricle and cause oxygenated blood to leave the left ventricle through the aorta and return back to the lungs via the pulmonary artery. So because of this, the heart has to pump harder due to the increased load on the pulmonary system. PDA is one of the most common heart defects and occurs twice as often in girls than in boys. Symptoms are often unnoticed during infancy. The child may experience dyspnea, Um, the radial pulse is bounding on exertion, and they may have an unusually wide pulse pressure. Cardinal symptom, they may have like a machinery type murmur. Diagnosis, there's a 2D echo. It helps to determine the blood flow across the PDA. So for treatment, we have indomethacin drug therapy, which often closes the PDA in preterm infants. Surgery is performed on term newborns to prevent CHF, embolus formation, and other complications. The ductus may be ligated by an incision in the chest or through thoracoscopic surgery, both of which eliminate the need for a large chest incision. Non-surgical methods, such as the insertion of a coil into the PDA to occlude it, may be done via cardiac catheterization in a cath lab. Prognosis is excellent with treatment. This concludes part 2 of cardiac dysfunctions in the pediatric population.